cases a day to actually safely reopen the economy. All right, so in terms of death, Illinois now has more than 1,000 COVID-related deaths, and of those 68% are in Cook County, and Chicago had 514 deaths, which is about 38% of Illinois death cases, and 56% of Cook County cases. So what this shows, in fact, is that the first, we know that the cases and deaths are highly clustered in Cook County and Chicago, but if you look at the proportions of Cook County confirmed cases and deaths, deaths occurred at a relatively greater frequency outside of Cook County compared with the case reports in Cook County. So Cook County accounts for, like I said, 72% of confirmed cases of Illinois, but 67% of deaths. So why would that be, right? So main reasons for this, I mean, you could imagine a lot of reasons why, but one issue that I think we need to pay attention to it is hospital capacity. By far, hospital facilities are clustered in Chicago, so we may be seeing the effect of poor access to advanced COVID care, right? I was talking to U of I hospital, Maya Square people, and they say UI health capacity is at about 75%, and Northwestern Hospital at about 80%. So in response to the current crisis, Illinois issued a series of executive orders going back to March 9th, when Illinois issued a state disaster declaration. And within a week, all large gatherings were canceled. And on March 16th, all schools are closed. On March 20th, the shelter-in-place order was issued. And on April 1st, all social distancing policies were extended to the end of April. So now we're reassessing whether we will be able to open by May or not, right? The chances are we might have to expand social distancing policies a little longer. So are these executive orders actually making a difference? It's still early, but you can see here the number of new cases, not the cumulative cases, but new cases daily. It seems like the proportion of new cases has been going down since the first week of April. But now it became very clear that this pandemic disproportionately affect minority communities. What's interesting is actually how late in the process we started talking about the issue of inequality. It's not until the beginning of April, news media started to highlight the issue. As of April 20th, there's 915 deaths recorded in the Cook County Medical Examiners database. 51% of COVID-related deaths in Cook County are African-American, while less than 25% of Cook County population is African-American. And in Chicago, African-Americans make up 56% of COVID death, but just about 30% of Chicago population is African-Americans. So how do we understand this racial disparities in a seemingly natural disaster, right? Because COVID-19, you know, coronavirus pandemic is in a way natural disaster. So one of the reasons why I got involved in this current pandemic so early is that I teach social vulnerability class this semester. So in this class, we use hazard data to model vulnerability and its effect on disaster exposure and outcomes. So for example, we use hurricane data and Chicago heat wave data to model social vulnerability. And so we switched to examining COVID-19 and social vulnerability very early on. So I recruited a lot of my current and former students, and they've been very active in this effort. Currently, my students are tracking number of nursing home cases, prison transmission, racial disparity, and the issue of low-wage workers, essential workers, and they're putting out policy reports on these issues. So what I mean by vulnerability, right? Vulnerability is a key concept in understanding risk and outcomes of exposure to disasters and hazard. Risk, in a way, as a technical term, is very narrowly defined as a value neutral term, but vulnerability is in fact shaped by social, economic, and political context. And so even natural disasters are not quite natural, right? Vulnerability includes biophysical vulnerability, like physical characteristics of the hazard and environment, and social vulnerability to determine an overall place vulnerability. So more specifically, social vulnerability looks at social, economic, and political characteristics that shape community capacity to deal with issues and recover from natural disasters and hazard. And I will argue that vulnerability is socially constructed through historical, social, and economic processes and practices. And social vulnerability research focuses on geographic distributions of risk, hazard, and vulnerability rather than thinking about risk at the individual level. So in fact, we're living in risk society. What I mean by that is that social institutions, right, social structure produces and reproduces social inequality and the spatial patterns of disadvantage and privilege. And so we understand that there's a significant relationship between nature and society, right? Structural factors determine disaster outcomes, even though disasters in and of itself it may not be man-made, right? So again, natural disasters are not really natural. So why do we see spatial clusters of COVID-related death in certain areas? I will argue that it's because of existing spatial stratification, right? It includes spatial concentration of poverty, social exclusion, and racial segregation. And the result of it is that health inequality. So social vulnerability produces health inequality and the clusters of risk factors. Because it's structural, we see spatial clustering of vulnerability in not only COVID-19 crisis, but in all other disaster events in the past. So for example, Chicago heat wave in 1995, we know that minority older adults died more often than other population groups. Hurricane Katrina in 2005 is another example. Even after years after Hurricane Katrina, there only a fraction of people from predominantly minority communities were able to go back and rebuild. And recently, Hurricane Maria in 2017, we also saw racial disparity, and now it's COVID-19. So social vulnerability is measured using what's called social vulnerability index. It's a composite score using, principal component analysis, right? So for this analysis, I use US Census data, American Community Survey, 5-year estimate between 2014 and 2018. And it includes percent poverty, percent less than high school education, female-headed household with children, median household income, and employment ratio. For risk factor, it's a health risk factor score, right? Again, it's a composite score using a factor analysis. I use Chicago Health Atlas, and for Illinois cases, I'm using data from Illinois Department of Public Health, but the problem is it's at the county level hospitalization data. So this risk factor score includes the rate of heart-related death, stroke death, the rate of asthma, hypertension, diabetes, obesity, and smoking. And I look at racial composition, especially percent African American and percent white difference, right, to examine the independent effect of race and ethnicity. I have to say racial composition is usually included in the social vulnerability index, but I pull these out just to look at sort of separate effect of race on COVID outcomes. All right, so here's the county level confirmed cases and death. So as you can see, the majority of events actually clustered in Cook County, and some in the downstate here in the middle and southwest. So because now confirmed cases are reported at the zip code level, so you can go down to the zip level analysis, but still death cases not available at the zip code level. Anyway, overall, here's the zip code level and then the county level. Overall, you can see confirmed cases are mostly in Cook County and Chicago, but already you can see the difference between zip code level maps and county level maps. So county level, data are quite unreliable. But what you need to think about is this. I just said that the cases are clustered in Cook County, but it's not just Cook County, but color counties, right? So here, Kankakee shows increased cases. Will County and sort of here up Lake County also saw increased cases. And then the next map shows here we see cases increasing in down south, here Peoria and Champaign area, and then southern part of Illinois. Right. So here's the social vulnerability index. You can go down to census tract level for social vulnerability index because I'm using US Census data. Again, the importance of data and the role of census data in sort of examining and estimating vulnerability is very important. And just because confirmed cases are at the zip code level, I sort of did a social vulnerability index at the zip code level, and then here side by side zip code and the census county level. I mean, you could see a little bit of clusters of it, down south here, but mostly Cook County area. All right, so here's the risk factor score. The first problem with data and the importance of data that I want to say is that because of the lack of data beyond Cook County, it's very difficult to examine how social vulnerability and risk factors are affecting COVID outcomes for rural Illinois. I was lucky enough to find some, old data, hospitalization data for Illinois, but Illinois as a whole, it's really difficult to find comorbidity data. But again, county level data is unreliable because there's great variance within a county. So the county level data can't really tell us more granulated information. All right, so I think for now, let's just focus on Cook County and Chicago only because we have better data, right? So here you see case and the death for Cook County. As you can see, both clusters on the west side and then south side of Chicago, but confirmed cases are more spread out. And pay attention to outside of Chicago, right? South of the city. These areas actually are predominantly African American communities as well. Okay, so here's the map of death cases. I mapped death incidence addresses using the Cook County Medical Examiner's data. The map on the left show all COVID-related deaths in Cook County, and then the map on the right, I highlighted red for the African American deaths. Clearly, predominantly Black communities here, west and south side, particularly on the south side of the city, are experiencing clusters of death. First thing that I want to tell you about Cook County Medical Examiner's data. I mean, we're lucky to have this, public data to look at race in locations, but what I found was that the medical examiner's data do not reliably code Hispanic ethnicity. So a lot of these potentially Hispanic death cases are simply recorded as white. So again, because of data, we're not being able to actually see the effect of a big major minority group, and I worry about the lack of data on Hispanic communities because of because we do know that low-wage workers, like essential workers and labor workers and service workers are predominantly Latinx, and we're not actually capturing the effect of those low-wage work and ethnicity at this point. All right, so I'm zooming into Chicago, right? Again, highly clustered death on the south side. Here you see, but I guess my question for you is that why does COVID-19, a sort of a natural disaster, produce highly racialized outcome, right? I already talked to you multiple times, but I will argue again that minority communities are disproportionately affected by existing inequalities, which then result in health disparity, right? So, and all of these have distinct spatial patterns. So let me show you here. You can see here risk factors for COVID death, comorbidities are highly concentrated on the west and south side of Chicago. Isn't that amazing? Just by looking at the rate of heart death, the first map, and then obesity, diabetes, smoking, and hypertension, the spatial patterns are very, very much consistent. These maps, really consistently show elevated risk factors in predominantly African American communities. So, because risk factor scores are computed from these separate comorbidities, you see risk factor score also showing spatial clustering of west side and south side, and the similar pattern can be observed for the social vulnerability index maps here. So here's risk factor score, and then here's social vulnerability index score. Right, so let's just compare side by side. Looking at the social vulnerability index, risk score, and percent African American residents, predominantly Black communities in Chicago were disproportionately affected by both social vulnerability and health disparities, I would say, even before the current COVID crisis, right? So here, I did some, hotspot maps, the red areas, right, between the high social vulnerability index and high risk factor, and also looking at the percent African Americans and COVID-related death rates. So the bivariate correlation between percent Black and social vulnerability was about 0.48. While the correlation was negative 0.49 between percent white and social vulnerability. Also, the bivariate correlation between percent Black and the risk score was at about 0.53, while it was negative 0.56 between percent white and the risk score. The bivariate autocorrelation is called Moran's I between social vulnerability index and the risk score was 0.52, which means social vulnerability index and health risk score are highly spatially correlated. And you can see here clusters on the south side. And the autocorrelation between percent Black and COVID death rates was 0.41, while the rate correlation was minus 0.33 for whites. All right, so I just want to say that this concentration of confirmed cases and death actually extend down to sort of communities south of Chicago here. Like I mentioned, these are still predominantly Black communities. And so the reason that I'm pointing out is that, we started thinking about community outreach, and especially Chicago Department of Public Health is very active task force and, outreach. They even say it's not just outreach, we're a strike team. But we really need to engage Cook County Public Health, right? Because, it's not just Chicago, but, south of Chicago, Cook County is also affected disproportionately by the current pandemic, right? And you can see death rate also increased the south of Chicago, right? So to summarize the relationship between race and social vulnerability and risk score, here's a simple correlation matrix. Percent Black was significantly associated with social vulnerability risk score and the death rate, right? On the other hand, percent white is actually negatively associated with vulnerability risk and death. For percent Hispanics, it's really interesting because it's not related to social vulnerability and risk score, but it's negatively associated with death rates. So I keep going back to percent Hispanics and Latinx communities is because we're not actively really, examine the effect of exposure among low-wage workers and essential workers, particularly in Latinx communities. And I really believe that that should be something that we need to focus a lot more on. All right, so here I'm showing you sort of a model. Also, it's a summary of a structural equation model as well, to try to explain the increased COVID death in African American communities, right? I'm showing the total effect only, but to summarize, mainly health risk score has significant direct effect on the death rate. Social vulnerability index effect on death is primarily through the health risk score, and both percent African American and social vulnerability index were significantly associated with health risk score, meaning that predominantly Black communities are more likely to have increased social vulnerability, and social vulnerability contributes to high rates of health risk that actually increase the likelihood of dying from COVID infection, right? So I will argue that, existing inequality is often highlighted in emergency conditions like COVID crisis currently. The disproportionate effect of COVID-19 on African American communities are sort of a reflection of racial inequality that existed before the COVID crisis. Especially Chicago, which is like one of the most segregated cities in the U.S., may be showing how racial sort of segregation intensifies disparities in the COVID outcomes. And so I think as we respond to sort of minimize sort of uneven burden of the COVID-19 pandemic, health policies actually need to pay attention to a broader social, structural inequality. And and I think that public health, right? This is a public health crisis, but public health can only be protected by sort of mitigating, not only mitigating transmission, but mitigating social vulnerability of all communities, right? So just last thing that I want to show you here is this. So I'm working with U of I MySquare drive-through testing capacity, and I just mapped, initial data that I've got, and you already see that our U of I, drive-through testing is not reaching out to the most affected areas. The good news is that we actually opened up South Shore drive-through, and then here Cicero area. So we're hoping to have more testing on the south and west side of Chicago. Okay, so just want to say that I agree to do this talk because I think it's a good opportunity to think about the role of census data, right, in sort of emergency response. And also I want to highlight, sort of a severe problem accessing reliable data. So we'll need to start thinking about sort of a long-term data and data science capabilities for the current, COVID crisis, but for future public health responses. All right, thanks. I'm just gonna stop sharing, and then we can talk if you have questions.
Thank you so much for sharing that. Rakai and I both have some questions we want to ask in general, and then we'll open it up to anybody else. Questions you have, we'll just have a conversation about it all. Thank you so much again for the presentation. I was just curious, what from your research did you find most surprising as you were going through? I mean, you're taking a lot of big data sets and putting all these things together. What did you find most surprising?
I think what's most surprising is how vulnerable we are in terms of, you know, responding to crisis and also, you know, data. I mean, you would think that it'll be very easy to get, you know, health risk scores, right? To try to pinpoint where the most vulnerable population might be, but you know, some of my students actually have been looking at prison data, right? Prison transmission, but it's nearly impossible to get a good sense of what's happening in prison, for example. So personally, I've been, you know, getting jails and prison data to sort of a score who's the most vulnerable, so that they can be let out. But even after I did all that risk, you know, like risk scores and things for them, you know, like Illinois, but also, you know, Baltimore prisons and things, they don't want me to talk about it, right? Because it's confidential data. So I can't share with you any of those information. But I think that the most surprising thing is that the lack of infrastructure in terms of data, right? And again, I think, you know, Dr. Smith will talk maybe a little bit about the importance of Cook County, U.S. Census data, is that only reliable data that we can get is census. You know, I was talking to you just before our talk, is the idea of invisible men, right? Certain group of people are not counted, right? So prison population is one, you know, census doesn't count. You know, institutionalized group at their residential areas, but also undocumented immigrants, right? So again, I'm, you know, sort of telling you about the importance of looking at, you know, predominantly Latinx communities, but you know, try to look at the unemployment data, right? Unemployment claims, which obviously do not include undocumented workers. So I will say, you know, I spent years to build a data repository so that we can have, you know, sort of common data sets and measures for anyone who's doing health disparities, health equity research. But, you know, it again, in the midst of crisis, we feel, you know, that, you know, the lack of data and infrastructure again.
Yeah, thank you. And as you mentioned, one thing I do want to say is the census, everybody should be counted, including undocumented immigrants, that we, you know, everybody is counted in this. And I think that's something that's not communicated as effectively. And we did have earlier in the year that they were trying to include a citizenship question on the census, which is not being included. And I think especially we have a lot of communities that are still afraid, you know, to fill out the census, and so it's important that we communicate effectively and are really getting the real word out there, so that we can get as many people counted as possible.
So I just want to sort of add that why do we see fewer, sort of relatively speaking, you know, Hispanic confirmed cases, right? That too, you know, it's not just me, but you know, if I go in and get tested positive, then you have to, you know, be subject to contact tracing, which may include undocumented relatives or family members. And so, you know, it's a very anecdotal sort of currently people talking about it, but if, you know, I have to risk my family, right? I'm not going to go in and get tested. So census, yes, the issue, but that's sort of replicated in terms of testing participation as well.
So we have a question from Taylor Long, a couple questions. Do you think the 2020 census stands to correct some of the issues with data access and accuracy in counting?
So Janet, do you want to talk a little bit about that? You probably know.
Sure. Sorry. Sorry I came in a few minutes late. You know, it's interesting because the census data, you know, there are ways to account for for undercounting, right? So they have methods for that. But I haven't seen anyone really talk about if we got 100% count, for example, in the state of Illinois, which is our goal, how that would change significantly what's collected, because the big thing here is there's sets of questions and results from that. The questions will not change. You know, we're going to have the same set of questions. So I think some of it is there are limitations to what the census can do in general. So what I'm trying to say is that, like, the health related questions that you know, the joining of data that Dr. Kim is doing is really about bringing census data, socioeconomic demographic data, joining it with health data. And I think excuse me, I have an allergy cough here going. Some of the challenges we have is that those data sets, as she said, don't work at the same scale. So I'm not trying to not answer your question. I'm trying to say is that I think some of our bigger concerns is this larger ability to work across data sets, even if they're from different sources, so that they can speak to each other and address some of the problems you see, the maps you showed. Thank you, Dr. Kim. Also about the difference between a county level versus a zip code versus census tract. You can see concentrations so much more when you're at that finer grain. So I think the bigger question we should be asking, because of this sad event, to bring it up, is how do we make sure that we have a uniform set of health data that can help us and align with the census data that we get now on an annual basis, right? I mean, the American Community Survey is limited somewhat, but at least it's there on an annual basis. So hopefully, we hope that we'll get better information from a higher response rate in the census. So we'll have less to rely on what the census does, which is in terms of interpolations and all these kind of things that they do to make up for what's missing. Sadly, they've been doing it for decades now, and they have become proficient at it. We don't want that to continue, though. And I think the bigger question we're going to have to see is getting, and this kind of responds to Taylor, to your second question, is what is the response rate going to look like now because of COVID-19? We've been watching it daily. I'm obsessed. You know, on one hand, with COVID-19, we want to flatten the curve, not the census. We don't want the census to flatten. Sorry, you didn't realize. I'll show myself so you can see. I have nothing to hide. I just was being discreet there. But, you know, it is an important thing to think about is what are we going to see? So right now we're at almost 57 or 56%. No, I think we're at almost a 57% response rate, which sounds great considering that in 2010, we were at 73, something like that, maybe. But the map shows very clear unevenness in terms of response rates. And it's mirroring what we knew from 2010, which is lower response rates in communities that are predominantly African-American and Latino. So I think what we're worried about right now is just like the question mark about why are the Latinx communities maybe not showing up in the data for COVID-19. We see the same concerns in the census response rates, not consistently across the state, but it's there. And I think some of it may be COVID related. I think a lot of it though is all the other factors that we knew going into this, and COVID's just making it worse.
Mm-hmm.
Right?
Right. So I totally agree with you. You know, a crisis like COVID-19 actually, you know, accentuate the existing problem. it's not, you know, introducing new type of inequality, but it just you know, unveil what's, you know, hidden, you know,
Yeah.
before crisis, right?
Oh, you just put yourself on mute.
I've been doing too long. I've been 4-hour Zoom meeting before this. The thing that I think is really important is in the communities that we knew were called hard to count based on low response rates from 2010, the outreach efforts that were planned before COVID-19 were specifically responding to what they knew was reasons why people don't respond. Some of it had to do with internet access. We're all seeing that now, COVID-19. If you're a student at UIC, some of you may have great internet access. Some of you may not have it at all, and you're struggling to get through. And you know, UIC is trying to do its part, and others are too, but you know, they were going to offer up sites for people to go to that they felt comfortable in their community, that they could use the internet. The other thing is the census uses a term called trusted messenger. So who's your trusted messenger when you're in a community and you're undocumented? It's probably not all the social service agencies available to.
Yeah.
It might be organizations like ICER, which has a long-standing history of working in communities with undocumented people, as well as their local connections. And those are going to be the door-to-door knockers to say, please don't be afraid, fill this out, it's really important. That's all stopped, right? And you don't have the internet to reach out to people because a lot of people in those communities don't have internet. So it's complicating what we're going to be, these really incredible outreach efforts to get people to sign up, to finish the census, to do the census. So we're going to have to really understand that impact as well.
So we have 8 minutes left. I think Janet, you answered a lot of questions that I had about these pre-existing inequalities and how they've just been, you know, they're more in the light now. And I was speaking earlier about how Lightfoot is trying to make this racial disparity task force, and also the governor of Michigan has also been in talks about doing such. So, and it's it might be so why now, as Dr. Kim said earlier, then Hurricane Katrina, Maria, 1995 heat wave, like we see what happens every time. So why now? And what would that look like for actual equality or just equity?
What's your thought, Dr. Kim?
Yeah.
I don't know if I understand your questions correctly, but in terms of you know, sort of a city and state task force, you know, outreach programs, you know, it's strong, but you know, I can only tell you my personal experience right now. We've been doing this community the capacity sort of survey, and within like 2 weeks we got like about 70 surveys. You know, we're not asking, you know, who are you, but it's which community you serve and what you need, right? And so I do see that existing sort of community organizations are sort of aware of, you know, how important it is to garner, you know, like resources and actually reach out to community, right? So my friend going out, you know, as usual, right? And you know, they're distributing not only information but bandanas, you know, like masks, you know, homemade masks and things like that. Last night I was talking to my friend who's the director of Roll Call, which is a you know, reentry service, you know, program. But you know, she was telling me about how difficult because of COVID, and you know, people who are already sort of justice involved, and especially youth, I mean, this, it's really difficult because, some, youth kicked out of the house because of his, her delinquency issues and family issues. But then, you know, outreach workers are not available, right?
Mhm.
So she's basically saying, well, I really, I don't care. I'm going to go out and meet, you know? So if you do that, then, what kind of social distancing effort do you need to think about, right? But, just to, Mile Square, we request some money. Our goal is to make 5,000 packet with, accessible information with, homemade PPEs, to really go out on the street, actually face to face, far away. But so those efforts are, like really actively now. So you have to, see that our effort now, sort of focusing more into
Right.
really going out into the community. And again, the importance of data, right?
Yeah. I think I want to just sort of add to that. I look at this as, well, to quote our past mayor, that you don't let a good, crisis go to waste, when he was under Obama. So the concern I always have, given the patterns or the history that was recited in terms of these different crises, is that, like right now, what I'm watching and applauding is the response, the immediate response to the needs of the community that the data points to. So opening up more testing sites, right? That's great. And the PPE. So those are all great. So I don't want to say they're not great. But the question becomes, what do you do, or what do we do collectively as a society to change things in what will be, a time when this dissipates? I'm not going to say it's going to completely go away, because I think we're all getting, different information now suggesting we'll have another wave of this. Which is why it's interesting for me to watch advocates that I know who yesterday were, for example, protesting at City Hall because they didn't want to give the mayor too much power to make decisions around emergency management money, because they wanted to make sure the money went to the communities that need it the most. And there's a long-standing history of suspicion in the city that doesn't happen. And so, I respect their concerns and positions, but it just says a lot. And some people are like, oh, well, you don't need to be protesting now. It's an emergency. It's like, now is the time to insert the social justice issues into this discussion, not just in the immediate response, but in the long-term response. And so I think that's the thing that we all have a responsibility of, is how do we sustain this concern beyond, the immediate pandemic issues that we're dealing with and seeing.
Yeah, I do agree with you. And I think that this crisis could, it's an important moment, whether we are going to actually expand our sort of power to really, insert ourselves and improve health equity and general inequality, or we could be totally crushed, right? But, what I see now, I don't know, Janet, but, I don't, to be honest, I don't see, we're doing it,
Yeah. I agree with you. I do think maybe it's too soon, but I think it's our responsibility to keep, I say ours, collectively, we, society. I do have to say too, is that people have been looking at the differences in how the experience of COVID-19 is being recorded. A friend of mine sent an email this morning. She goes, some people are just bored and doing puzzles. And she said, I have to remind people there are people in community front lines, not just the hospital front lines, in the community front lines, and not just, also the essential worker front lines, but in the community front lines. And I think, so the city of Chicago and the different foundations came together and raised, $20 million to get out to those frontline organizations. That is not enough. And it's not enough because they never had enough to begin with to do the work they do on a daily basis, and then add to it crisis. and then add to it all the complications of trying to reach people who can't be reached easily unless you're out there. And so I think we need to also kind of talk about just the daily experience of community development workers, people, and I'm saying the broader sense of, public health workers, et cetera, but who are doing work in community, and how we learn from this and change things because of it. So that's my dream.
Mm-hmm.
Would you be able to share the PowerPoint
Sure.
with? Okay. Karen, do you have a list of everyone from the
I do.
Eventbrite? Okay, sweet.
This was also recorded, and it will probably be up on the Public Health Department's website for UIC, so you might be able to access that there as well.
And the PowerPoint's embedded in it, so yeah.
Yes.
Thank you.
Great.
Thank
Yeah,
you,
thank
everyone.
you, everybody.
Okay, stay safe and be well.
Thank you, everyone.
Thank you, Dr. Kim.
Thank you. Thank you.
Thank you,